Hi, everyone. Today is the second in a two-part series that I started last episode about substance use and when parents use substances that alter the way that they parent, such as alcohol, marijuana, sometimes other drugs, and how we handle those issues in the family courts. Last time, what we mostly talked about was how traditionally this is approached in courts. This, for decades, has been handled in essentially the same way for most courts, most judges, most lawyers. We look at it as we need to go test the person and we need to really um, stop the parenting time pretty quickly and have a very, very careful route back in terms of parenting time beginning again. And sometimes that can be, I don't know, maybe this is too big of a word, but quite draconian in the fact that we end up reacting in a way that doesn't allow children to continue to see that parent as frequently or sometimes at all. Parent has seen of the other parent's use of substances. You can just understand that would be a parent saying, wow, my spouse drinks like crazy. There's always 12 beer cans in the recycling bin, or I know that she drinks a bottle of wine every single night, or two bottles of wine every single night, whatever the thing that the other parent is saying. Now it gets a little more, even more dicey when you now have parents in different homes. And now we don't really know what that other parent is doing. We just have a lot of suspicion and uncertainty based on previous behavior. So even if the person is in recovery, will that parent relapse? Will that happen in front of the child or when the parent needs to be driving the child, caring for the child, things like that? Certainly, we ask questions of how can we be sure that we're protecting a child? Obviously, a lot of what we are concerned about is dependent on the child's age. Are we dealing with infants? Are we dealing with toddlers? Are we dealing with children who can protect themselves at all? Or how vulnerable are they? Not that all children are not vulnerable. Of course, there is a degree of vulnerability for all children, but certainly when kids are younger and unable to really articulate what's going on and unable to protect themselves from that kind of situation, then we have more concern. What if the child wants to return home and isn't able to return home? What are we supposed to do with that child? How soon should we be encouraging visits, and where are those lines of protection? I will share here, I have one of the first things that Dr. Tabashnecke mentioned to me when we spoke, and I think she mentioned this when she spoke to our lawyers at the conference, is this book, which I'm going to hold up here on the video, and I will um, I'll post a link to it. It's called Beyond Addiction. It's a guide for families, how science and kindness help people change. The treatment protocols, I will say, for this medication, use of medication to treat if in early recovery, what they can do is they can go conduct routine drug testing and require counseling like weekly or monthly, dependent on what's needed as decided by a treatment team. Letting a doctor drive medication decisions, not the individual, and not tapering off too early. All of that is found to be more effective. And I would note as well that 50% of users relapse within a month of being weaned from Suboxone, which is one of the typical MAT medicines used. The lower the dose at the time of weaning, the better the outcome. And then also, Dr. Tabashnek warns that we should be mindful of financial and logistical barriers. We don't want to create plans that are going to cause um, so many financial and logistical barriers that a parent is going to fail. And why do we not want to do that? We don't want to do that because that's bad for children because of the attachment pieces we talked about previously. And so the things that need to be thought about in this category is things like supports if relapse and recurrence occur, incentives for the user of the substance to be transparent, individual therapy, scheduled drug and alcohol testing or alcohol testing if feasible. For some people, we need, for example, some treatment programs with integrated treatment for mental health and substance use disorder. There's also individual support peer groups And it's not always AA or NA, Alcoholics Anonymous or Narcotics Anonymous. Other options are out there, including smart recovery, mindfulness based groups, and things like that. It's important that the individual decides what's helpful to that person and have a voice in that. And it's also important that treatment is immediately available. We want to sort of strike while the iron's hot because motivation can wax and wane for people regarding um, trying to be open or being open to the type of treatment that is out there, and that can rise and fall based on the timing of the case and the situation of the parent. And then we already talked about medication assisted treatment, which is another important thing to think about. This book I've been talking about, Beyond Addiction, and a lot of this research, and also Dr. Tabashnecke's work, discusses a lot that treatment for people with substance use disorders is most effective when family or loved ones are included. So, when we have these cases that need to be delicately handled when substance use is at an issue, a mega analysis called Optimal Parenting Time Decision Tree, based upon shared parenting mega analysis, which was at the Association of Family and Conciliation Courts in Toronto in 2014, presented by Leslie Droz. I'm not sure I'm saying her name right. Dr. Droz, it's Drozd. Dr. Nancy Olson, Olesen, and our own, I will fondly say, since he's been a podcast guest, Dr. Michael Saney. And so these three people did this presentation and created this optimal parenting time decision tree. And I'll link that separately on my show notes so that you can take a look at this. But all professionals, judges, lawyers, substance use evaluators, and parents need to be thinking about these and therapists need to be thinking about this sort of decision tree, and I will talk you through it in case you're not looking at it. So essentially at the top, we have a bubble that asks, what is the optimal parenting time that the child should spend with each parent? And then we have a row of columns basically, and I'll just go through each one. So first, we look at safety issues. We look at child abuse, neglect, physical abuse, psychological abuse, sexual abuse. We look at intimate partner violence and substance misuse and abuse. Okay, so obviously safety issues are paramount, and we have to be sure that we are meeting those needs. Next, we look at the child's strengths and weaknesses. The child's adjustment and resiliency, the child's temperament, the child's perspective and wishes, and the child's age and stage of development. I would add we've got sibling interactions, then we have to consider that as well. And that does go into the third category on this decision tree that is about the child's relationship. So it's the child's historical relationship with each parent, the child's current relationship with each parent, the sibling relationships, which is what I was just commenting upon that we have to consider. Sometimes we have one child who's presenting quite differently than others in various ages and stages and maturity levels, depending on the sibling group of that family. And we have to consider that. The child's relationships with extended family and the child's relationships with peer networks. Fourthly, so again, we have safety issues, the child's strengths and weaknesses, the child's relationships. The fourth is mothers and fathers' mental stability and capacity. So that involves the mental stability of both parents, the parent capacity. And the things we think about parent capacity are the parent's attunement to the child and to the situation, the ability to be nurturing or nurturance, the ability to be protective, show protection, the ability to teach, the ability to promote child's separate and unique needs. And I would indicate that's true across sibling groups as well. So it's not just one need that's met, it's the separate and unique needs of each child and the children as a group. Also within the parent's mental stability and capacity, we would have the consideration of parent problems that might exist. Maybe parents are hypervigilant or intrusive. Maybe they're too lax or too rigid. Maybe they're self-centered or enmeshed. There's a variety of things that can come into play here regarding the parents' mental stability and capacity. Next, the fifth category is mother's and father's relationship, their communication, whether either or both are doing gatekeeping, and whether that is adaptive or maladaptive, facilitative, restrictive, or protective, and whether the parent supports the other parent's autonomy as a parent. And then lastly, or I guess this would be the sixth thing, is logistics. What is the distance and time between homes, the proximity of the child's educational and social networks, the degree of synchronicity of the parents' calendars, religious and holiday schedules, exchanges, where they do them, when they are, and the transition of the child's items.